Good morning, everyone. I'm from the assistant professor from the Department of Pathology. I'm going to take pathology second year class. My topic is CSF findings, meningitis and charts. So, start from the normal brain structure. What are the maps and where the CSF is present? So, as you can see, this is the skull bone, this is the cerebrum, and so the meninges. Meninges generally have three layers: dura mater, arachnoid matter, and so the layer which is adherent to skull bone is known as dura mater, and the layer adherent to the brain cerebrum that is pia mater. In between, this is the layer that is arachnoid matter, and the CSF is present in between sub in between arachnoid and pia. That is known as subarachnoid space. So generally CSF is lying here. This is the brain part and it is connected to the spinal cord. Similarly, this is the spinal cord, this is pia mater, this is arachnoid and dura. So this is the black one is the subarachnoid space where the CSF is present. So what is CSF? CSF is a ultrafiltrate of the plasma and it is present in between arachnoid and pia mater. So generally the cerebral cortex and the spinal cord, they are suspended and bathed in cerebrospinal fluid. And it is present, it is produced by the choroid plexus. Choroid plexus, they are the lining of the ventricles. So they are produced by the choroid plexus and they are reabsorbed by the arachnoid villi. The cortex and spinal cord, they are, as I told, they are surrounded by the three layers, so known as meninges. So this is CSF that I already told. It's the ultrafiltrate of plasma. It appears as clear and colorless, and it is used in ventricles from the choroid plexus, and it is present in all these layers. So this is the higher magnification. This is the grains, biometrics, this is the subarachnoid space. So what is the composition of CSF? As I told that it's a ultrafiltrate of plasma, so it also has some general composition. Like its normal volume is 100 to 150 ml and 10 to 60 ml in the, and it has a one opening pressure because it's a open space and it's filled with fluid, so it has some pressure in it. So its opening pressure is around 60 to 180 mm of water, and its appearance is clear and colorless. It has no clots, no cobweb. It has some cells composition, like blood, as the blood have WBC, RBC. The CSF is also have some cells. In adult, it is generally around 0 to 5 cells per cubic mm. And in infants, it's around 0 to 30 cells per cubic. And as the age progresses, the cells count slowly. And among the cells, the differentials are, they are generally mononuclear cells. 70% they are cells, like lymphocytes, monocytes, macrophages, and only 2% they are other than. So this is the normal composition of the normal cellular composition of the CSF. It does not have RBC. Normally, glucose is also present in CSF. As I told, it's an ultrafiltrate of plasma, so it has some glucose and protein. So normal glucose content is 45 to 80 mg per deciliter, and protein is 15 to 45 mg per deciliter. And what is this oligoglomerulates? They are some monoclonal immunoglobulins. They are generally not present in CSF bands, but in some conditions, like some diseases, these bands they are present. So that's why we have to look for these bands in some conditions that I will tell you. We have to look for these oligoglomerulates. So now, till now I have told about the normal CSF composition, where it is formed, which layer it is formed. Now we are talking meningitis. So these are the simple classification of meningitis. Like what is what do you mean meningitis? Meningitis is the inflammation of meninges. That is itis meninges meningitis. Similarly, if CNS is having infection, it is divided into two categories, like encephalitis and meningitis. So encephalitis is for brain infection and meningitis is for meninges. And among the meningitis, it is divided like pyogenic and non-pyogenic. Pyogenic word says that it's septic and non-pyogenic is aseptic. And among aseptic, it is further divided into tuberculous origin or non-tuberculous origin. And in non-tuberculous origin, it is further divided bacterial, fungal, viral, parasitic. In bacterial, it is spirochetes. Fungal, it is cryptococcus. Viral, it is enterovirus. Parasitic, it is Toxoplasma gondii. And in pyogenic, these are the organisms they cause pyogenic or septic meningitis, like Neisseria meningitis, Streptococcus pneumoniae, H. influenzae, Streptococcus pyogen, Staph aureus. So these are the some common examples of the infections in the CNS. So, what is meningitis and how the patient will present to you with meningitis? So here, it's a inflammatory process of leptomeninges and the CSF within the subarachnoid space. As I told you, CSF is present with arachnoid and pia mater, that is the subarachnoid space is filled with CSF. So, any inflammation involving that meninges, that arachnoid meninges and pia mater in between CSF also. So all these things, if they get infected, it is known as meningitis. The leptomeninges word is used for the combined layer of arachnoid and pia mater. Okay. Now, the patient representing. Patient will present as a headache. Why fever? Because it's an inflammation process. Headache because it's involving the head area or spinal cord area. So there is headache is there. Why the stiff neck and rigidity? Because the spinal cord runs in the neck region. So there is inflammation going on, so the neck becomes stiff and rigid. And sometimes the patient present with vomiting. Why? Because of increasing high intracranial pressure. The CSF, after the inflammation, CSF volume will increase. It will increase the pressure. So patient present with sometimes vomiting. And what are the complaint in children? Like irritability, lethargy, sleepiness, failure to take feeds, unresponsiveness, fever, and fontanel bulging. Children, they generally have fontanel in this year. So they are the open area, does not have the diffusion of the. So through that fontanel, you can see there is a bulging of the fontanel because of these intracranial pressure. So now what are the types of meningitis? I have in starting. So now it is like divided into acute and chronic. Acute is like sudden onset. So further acute is divided into aseptic and septic, that is pyogenic. Aseptic is generally caused by virus. So it is generally negative for culture. That's why it is known as aseptic. It is most commonly caused by virus like enterovirus, paramyxovirus, HSC. And pyogenic, it is caused by bacteria. So they are positive for culture. So these are the organisms that cause pyogenic bacterial meningitis, that is Streptococcus pneumoniae, H. influenzae, Neisseria. So we have to know what is aseptic and what is septic. The next is chronic. That is, it takes some time for its onset, like say weeks or months for the onset of that meningitis. So this is caused by most common tuberculosis, that is Mycobacterium, the most common positive organism for chronic meningitis. Other than that, Cryptococcus can also cause chronic meningitis. So we should be aware of that acute and chronic, and in acute it is aseptic and septic. That is based on the positive organism, whether it is positive for culture or negative for culture. Now, this is a simple tabular form representation of its composition also that I have that CSF has some its normal composition, but after that infection, that composition it alters. So how it alters? This is just the comparison table. As normal CSF is clear, but in case of acute bacterial, it's a bacterial infection, so the appearance will turn into purple. But in case of viral meningitis, as I told, it's aseptic meningitis, so it will remain clear. And in tubercular, it has a classical cobweb formation. It is slightly opaque and it has a cobweb formation. So this is the differentiation on the basis of appearance. Next, the pressure. CSF has generally normal pressure. So in case of bacterial meningitis, the pressure will increase. And in case of viral meningitis, it is like normal to moderate. It is not too high. So it's just like mild inflammation or viral. It's like an aseptic infection. So everything will be like normal. In tubercular, it is increased or it can decrease because it has a spinal block. After some time, there's a spinal block is there in tubercular meningitis. So the pressure will remain like static after some time. Now about the TLC count. Normal CSF, there is I told 0 to 8 or 0 to 5 cells over there, and they are more predominantly lymphocytes. In bacterial, acute bacterial, it is more than 500. Generally, it's more than 500 cells, and sometimes it reaches to 10,000. Like if you get any fluid and it is like full of fields of TLs, lymphocytes are there. So you have to, if not lymphocyte, if it is full of polymorphs or any WBC cells are there, you have to think of acute condition. And in case of viral cells, they are increased, but it is like up to 300. It is not as high as in bacterial meningitis. And in tubercular meningitis, it is high. It is higher than viral meningitis, but it is less than bacterial meningitis. So it's some in between this. And according to what type of cells, according to the differential, bacteria will have more of polymorphs. They will be full of polymorphs. And in viral meningitis, they of lymphocytes. Similarly, in case of tubercular, it is like initially they will have like polymorph. Later, it turns into lymphocytes. So next is the protein. What about the protein? So the normal CSF have like 15 to 45 mm per mg per deciliter. So in bacterial, protein level will increase. It's like 100 to 500. And in viral, the protein level is like mildly increased, like normal to mild. And in tubercular, it is static, like 50 to 300. And it's due to spinal block, it becomes static. So why there is increase in protein concentration in case of meningitis? So what's the, I told that meningitis is the inflammatory process. So whenever there is an inflammation, the blood-brain barrier will get disrupted and some amount of protein from the blood, they enter the CSF. This is also one of the cause of increased protein. Other than that, there is inflammatory process, some bacteria is there, virus is there, fungi is there. So our body responds, in response of immune system, they cause the cell lysis of these bacteria. They phagocyte monocytes and they cause damage to the bacterial cells. So there is a cell lysis is there, and the intracellular protein it's leaked, it's gained out to the CSF. That also cause increase in protein. So these are the two common cause of increase in protein in case of these meningitis. Now, glucose content is generally 50 to 80. So in bacterial meningitis, what happens? There is decrease in glucose content. Why there is decrease in glucose content? Because there is bacterial overgrowth. So all the bacteria they need sugar for their growth. So they use the CSF sugar, and there is decrease in the sugar content of the bacterial meningitis. But in viral meningitis, it remains normal. It is not decrease. And it came tubercular meningitis also. They also the mycobacterium also uses of the CSF glucose. So it is also decreasing tubercular meningitis. So these are the just comparison table that's telling about how we will able to differentiate bacterial, viral, and meningitis on the basis of appearance, pressure, TLC count, protein, and glucose. So How will you evaluate the CSF? When the CSF comes to the laboratory, how will you evaluate? So this is just the highlight from where you get the CSF. This is the lumbar puncture procedure. This is the lumbar puncture needle. So we have to go through all the pierce the skin, superficial fascia, ligaments, epidural space, and the dura mater, arytenoid mater, is the subarachnoid space. And from there, they take the fluid. And it's generally done between L3 and L4 pulses. So you should know the area where CSF has to be taken. So these are the needle. Just if you know that this is the shape and this is the stylet. What are the indications of LP? As LP is, this is the lumbar puncture. It's an invasive procedure. It's very harmful and dangerous procedure. We are not advised to go for lumbar puncture in all patients. So, what are the conditions or indication where the LP is done? That is, in case of examination of CSF in suspected cases of meningitis, or the meningeal involvement by leukemia or malignancy. In certain malignancy or in leukemia, that if CSF is involved by the blast, so we have to look whether which stage is there. So we have to look for CSF whether their blasts are present or not. In subarachnoid hemorrhage also, if CT is not available, we have to look for CSF, how it looks at it. In inflammatory diseases like multiple sclerosis, I told you about oligoclonal antibodies. So in case of multiple sclerosis, these antibodies, they are present in CSF. Other than that, neoplasm of CNS, they can also enter the CSF. To reduce, or in some cases of tumor, to reduce CSF pressure in benign intracranial hypertension also, we go for lumbar puncture. And in some medications also, administration of medications like anesthetics, antibiotics, anti-cancer drugs, they can also go by the lumbar. And in case of myelographic, some introduction of dyes also through lumbar puncture. Now, this lumbar puncture is invasive procedure, so it has some complications also. Like post-puncture headache is there. So the patient mostly complains with the headache. Why? Because we are inserting the needle into that subarachnoid space. There's a leakage of fresh CSF fluid. So the fluid, it has some volume, it has some pressure. So when we'll decrease the fluid, it can cause some headache. Or by going through that procedures, we can, if we are doing like aseptic condition, so it can cause like infection to the spinal cord. Sometimes during the procedure, hematoma can be formed, so subdural hematoma. And sometimes not most common condition of brain can be there. So these are this is this example that I am going to tell. This is a normal, clear, colorless appearance of the CSF. There is a generally there's a clear, transparent fluid, and this is bloody CSF. So the bloody CSF, it can be because of two conditions. One is traumatic and one is subarachnoid hemorrhage. Now, how will you differentiate whether it is due to trauma? Because we are going through that blood vessels, through that all the layers, some minute blood vessels can be there. So we can puncture those blood vessels. That is known as traumatic. Or some subarachnoid hemorrhage, bleeding is there. So the blood is mixed with the CSF and that is bloody CSF. So how we will differentiate on these two conditions? That after centrifugation, we have to centrifuge this tube, we have to centrifuge. And what we will see? The supernatant will be clear and transparent, then it will be because of trauma. But if the supernatant is like yellowish, turbid, then it will be because of subarachnoid. So this, on the basis of the difference of supernatant, we gave it. The last is the turbid CSF. In which condition we see turbid CSF? We'll see in case of acute bacterial meningitis, the CSF will be turbid. So this is the difference between, as I said, traumatic and subarachnoid. So gross appearance, the initial tubes For that CSF, we have to take multiple tubes because not only one test is done in that CSF. There are multiple tests like biochemistry test, serological test, culture test. These tests they should undergo. So we used to take multiple. So if it is chromatic lumbar puncture, the initial tubes will have blood move, and slowly the blood will decrease or the blood will clot on standing. But in case of subarachnoid hemorrhage, all the tubes will have uniform blood because the blood does not clot on standing in case of subarachnoid hemorrhage. And as I told, the supernatant after centrifugation within 1 hour of collection we have to. So in case of chromatic, it is clear, but in case of subarachnoid, it is pinkish, yellow, xanthochromia. Okay. And yellow xanthochromia develops 12 hours after the hemorrhage. And microscopically also, in traumatic lumbar puncture, in the subsequent tube, you will see there is decrease in the red cells count. And in subarachnoid hemorrhage, microscopically, the red cells count in all the tube. And sometimes you will see hemacentric leader macrophages. And there's one more. These are the tests we go for. The latest execution test. It is generally negative in case of traumatic, and it is positive in case of subarachnoid. And about the pressure also and fluid protein content also. Traumatic is because of trauma, so these are normal in case of traumatic lumbar puncture, and these are increased in case of subarachnoid. As I see some processes going on the brain, so they will cause increased pressure. So this is the microscopic of the CSF. These are the polymorphs. They are the many polymorphs they are present, and it's present in each case. It's present in acute bacterial. So these are the lymphocytes. They are present in case of viral. This is RBC along with lymphocytes. So it is present in traumatic lumbar puncture. These are the some monocytes, increased number of monocytes in the CSF. This is neutrophils and RBCs. They are present in CSF. These are the lining cells of the F5 and L. And these are the blast cells. As I told you, in some leukemias and some CNS leukemias, we have for the staging, we have for the blast cells in the CSF. And these are the malignant cells in CSF. Some case of some CNS tumor also, the malignant cells they come from the CSF. So this is the normal microscopic picture. How what are the normal cells they are present in CSF? So now I am telling a little bit about what are the questions because my topic is CSF and the charts. So charts this is for the MBBS students. Like when a 30-year male came to the OPD with fever on and off for 6 months with headache and foot. And on examination, the patients they have neck rigidity as it is telling that the patient is having a fever 6 months. And they're telling it's not an acute presentation, it's a chronic presentation, like 6 month duration is there. Patient is presenting with headache, photophobia. And on examination, there is a neck rigidity. And this is the gross appearance of CSF. As you can see, there is something called web type formation is there. And this is the CSF findings. It is slightly turbid. It has pellicular web formation on standing. Pressure is increased, like generally it is 60 to 150, but it is increased up to 100. Protein is also increased, like 160 mg per deciliter. It is up to 45. Glucose is little bit decreased, not too much decreased, like 42 will decrease to 36. And cell count is 156. Generally it is like 5 cells, but it is now increased to 1. It's not 5, it's high. And they are predominantly of 88%. So this is the scenario. Patient is presenting this complaint and these are the findings. So now go for these questions. So interpret the above findings and give your probable diagnosis. As I told you, I have interpreted. I'm going again. Like physically, we have to interpret like it is turbid, it has a cobweb on standing, it has an elevated pressure. Okay. Chemically, it is raised in protein, reduce glucose and increase cell count that is predominant of lymphocytes. So, what is the conditions? Cobweb, elevated pressure, raised protein, turbid, and predominant lymphocytes. So, it is chronic and tuberculous infections. So, what is the special stain used for confirming TB? We go for Zeal Nelson stain, that is for acid fast bacteria. And why this cobweb formation is there? I'm telling again, there is cobweb formation, cobweb formation. So cobweb formation is due to coagulation of fibrinogen, or that is fibrinogen to fibrin conversion. So with these bacteria, they convert these. So there is a cobweb formation there. Now we have to mention the complications of about like TB and encephalitis. That meningitis can turn up to encephalitis, and because of increased pressure, fluid formation, they can so this is the example, a common clinical and scenario for the tubercular meningitis. Now the next question is 16-year-old boy presented to medical fever, headache, vomiting, and neck rigidity, lumbar puncture muscle. So the age is younger, and the he is also presented with like fever, headache, vomiting, all sorts of signs of the inflammation. And what are the CSF findings? As this CSF is white and turbid, pressure is 280, it's very high. Protein is very high, it's like 1545, it's like 380 mg/dL. And what about the glucose? Glucose is increased, like 40 to 70, but it is 10 mg/dL. And the cell count is 1500 cells per cubic. That is very high. 5 only normal. Previous case it was like 150 cells, now it is in 1000 tons, and that too of neutrophils, like 85% they are. And what about the gram? The gram stain they show positive for bacilli. So the culture is positive, count is 1500, pressure is increased, glucose is decreased, on appearance it is turbid. So what is the diagnosis? So this is the case of pyogenic and bacterial meningitis. You can see this is the interpretation: cloudy, elevated pressure, reduced sugar, markedly elevated protein, increased cell count, predominantly of neutrophils. So diagnosis: acute pyogenic or bacterial meningitis. So what are the three causes of bacterial meningitis? Streptococcus in adults, older Neisseria, newborn there are Listeria. So strepto, Neisseria, and Listeria, they are the most common causes of bacterial meningitis. And what are the further investigation? How will you confirm the these infections? Like CSF gram stain. As I told, that gram stain is positive for bacilli. Culture sensitivity, blood culture, and imaging also. You can go for these tests for the confirmation of our diagnosis. So the next question is, a 4-year-old child, the history of few missed vaccination schedules presented in the medical with fever, headache, vomiting, and neck stiffness. The mother also complained of excessive sleepiness, photophobia, lumbar puncture muscle. So this is telling that a very young boy, like 4-year-old, and he has missed the vaccination, and it is presenting with this all the complaint information. CSF finding is as it appears as clear. It is not turbid. It's clear. Pressure is increased, but it is slightly increased, like 100 to 160 on. Protein is increased, but it is slightly increased. Glucose is near normal. It is not decreased. Cell count is increased, but it is slightly increased. Not as of tuberculosis, not as of bacteria. And that too of mainly lymphocytes. So you see there is some derangement is there, but they all are like mild derangement of protein, mild derangement of cell count, okay, mild derangement of pressure, and it is present in young baby, like 4-year child. So what are your interpretation? Clear and elevated pressure, mildly elevated, your normal glucose, increased cell count, that is of lymphocytes. So what is it? Aseptic meningitis or viral meningitis or lymphocytic meningitis. Because why we say lymphocytic? Because they are predominance of lymphocytes. What are the etiological agents for the upper? These are the most common viruses, viral meningitis like enterovirus, mumps, small cycle. Why we are telling mumps? Because maybe the patient then makes the vaccination, so it can end up in viral infection. And again, in this, what we do, we can go for PCR for the CSF for virus, because as I do, it's aseptic, so the culture will be negative in this case. So we can go for CSF PCR for viruses or blood culture or radiology to rule out any infection. So these are the examples of common meningitis conditions like acute bacterial, aseptic, viral, or chronic tubercular meningitis. So the classical scenario, how the patient will present to you. So thank you as I told everything. Thank you so much.